Well, good afternoon, everyone, and I wanted to welcome you to our webinar. Today we're going to be discussing the meaningful use audit preparation. This is going to be 45 minutes in its entirety. We are going to have time for questions at the end. Please use the questions window for any questions you may have, or the chat window. This program is being recorded and will be available on our website along with the slide deck. So let's get started. Our objectives today are going to be to identify the auditing bodies, to define the audit process, and to review the supporting documentation requirements that have been identified thus far in the audit process. Just to give you an overview of the EHR incentive program, the audit program, I just want to make sure everyone is aware of who is subject to an audit. Any eligible professional, eligible hospital, or critical access hospital that's attesting to receive an incentive payment for either the Medicare or the Medicaid EHR incentive program is subject to an audit. Now, the HITECH Act provided the Secretary of HHS or any person or organization that the Secretary designates the right to audit and inspect any books and records of any person or organization receiving an incentive payment. So HHS and CMS are really trying to do a balancing act right now. They want to maintain the program integrity, the EHR program, and they've built in certain program audit techniques throughout the program. Now, as well, they're trying to balance the goals of the different governmental bodies. The White House's focus really wants to reach many participants and have a broad impact by the program, while Congress is very focused on ensuring that the monies are going to the appropriate people and that the people are being paid for their correct attestations. So the Government Accountability Office, the GAO, they do auditing of governmental programs, and they have done a review of the incentive program thus far, and they've made some recommendations, and they've made 4 of them. The first recommendation was that CMS should establish time frames to evaluate the effectiveness of the audit strategy. Next, they recommended that they evaluate to what extent the agency could conduct more verifications on a prepayment basis when determining whether providers actually meet the Medicare EHR program reporting requirements. The third was to collect the additional information from Medicare providers during attestation that CMS suggested states collect that information for Medicaid providers during attestation, so getting more information collected at the time of attestation. And the fourth was to offer states the option of having CMS collect the meaningful use attestations for Medicaid providers on their behalf. Now, HHS has agreed with the first 3. They disagreed on the 4th recommendation to offer to collect certain information on states' behalf. Now, the auditing bodies that have been hired for these services for the Medicare program, CMS has contracted with Figlio and Company. They're going to perform audits on Medicare and duly eligible Medicare and Medicaid providers, that would be hospitals, who are participating in the EHR incentive program. The South Dakota Medicaid EHR incentive program currently is in an RFP process to contract with an auditing body. So who is Figlio and Company? These actually, they're an experienced group of accounting and auditing healthcare professionals. They specialize in audits of healthcare facilities to determine compliance with Medicare and Medicaid regulations. They've got extensive experience in cost report review and corporate compliance issues affecting acute hospitals, critical access hospitals, skilled nursing facilities, rural health clinics, physicians, and they have affiliations, as you can see on the screen here, with CMS, obviously the EHR incentive program, General Services Administration, Small Business Administration, American Institute of CPAs, and New York State Society of CPAs. So they have extensive knowledge about healthcare, which to me gives me some confidence that they know what they're looking for. And if you're interested, here is their website down here at the bottom. What type of audits are they going to be performing? Well, they have two sets. They have a prepayment audit and a post-payment audit. They also have prepayment checks that aren't considered an audit but more like a verification. So in addition to those prepayment edit checks that have been built into the system to detect any inaccuracies such as spelling of names or NPI matching a provider or an organization, they're also doing prepayment audits and post-payment audits. Now CMS is going to start, or had started, the prepayment audits in March of this year, and starting with attestations submitted during and after January 2013. So these prepayment audits are going to be a random audit and may target any suspicious or anomalous data. Providers that are selected for the prepayment audits will have to present supporting documentation to validate the submitted attestation before CMS will release payment. So when we're talking about the audit process and things further on in the webinar, this will apply to prepayment and post-payment. Now, post-payment audits began in October of 2012, and CMS, through its contractor, is also, they've selected these post-payment audits at random, and those people who are selected, again, will be required to submit supporting documentation to validate their attestation data. Just a FYI, if you have a prepayment audit, if you've been notified that you're having a prepayment audit, you will not have a post-payment audit in the same year. So I don't know whether that's good or bad, but if you get a prepayment audit, you won't have a post-payment audit in the same year. So what does CMS know beforehand? And this is good to know so you can kind of figure out how to manage your attestation and the risks that attesting has with it. So CMS knows that certain things about you, eligible participants, they know demographic information about the providers and organization. They know your patient mix that you have. They know some things about the software that you're saying you're attesting to. They know the functionality. They know the capabilities that that software has. They know the certification ID numbers. They know about your billing information. They've looked at claims. They can look at databases that they have in terms of the charges that you have submitted and been paid for. They know about your quality reporting data. They have the information that you have sent to CMS or PQRI. They have that information that they can look at. And also they compare peer groups, whether that is within your own geographic location or in the same type of specialty. So they're able to compare data. And if they find that you possibly are outside the range in certain patient mix areas or you don't compare to your peer groups, then those will be those types of things that they could flag you on. So when we talked about those verifications that are built in, I just wanted to show you some of these that they have. The eligibility flowchart, which I'm sure a lot of you have seen. This came out in the beginning of the EHR incentive program. And basically, as you go through this to determine your eligibility, this is where they will do checks. So did you perform 90% of your services in an inpatient hospital? And if you answer no, they're able to check to see if you are hospital-based. And I'm going to show you that in a few slides. They'll be looking at if you do have a 30% amount of your services furnished to Medicaid patients, if you're if you're attesting to the Medicaid program. They have ways to check your licensure to make sure you are a physician or dentist if you're going into the Medicaid program, or a nurse midwife, or nurse practitioner, or a PA. They are able to access information to see if you practice predominantly in FQHC or a rural health clinic. They're able to determine if you treat Medicare patients, and again, to check licensures if you have the appropriate license. So these things they are able to verify. And the hospital-based status, I'm going to show you an example that they are able to check, and you'll see right here when you register in the CMS registration program, you'll see that they do a check right here, and this is a DO, and this person was deemed to be not a hospital-based doctor, and they only had a 15% of their services were done in the hospital. So they are doing a check as soon as you register, and you can go ahead and look at that in all of your registrations. They also look to see if the provider or the organization has not been excluded from these types of programs, if they've been sanctioned to receive any monies from the federal government. So if you have any types of sanctions against you, they verify that at the time of registration and attestation. Also, the EHR certification number. Prepayment, they're doing a check against the ONC Chapel list. And then post-payment, they review and they will require documentation to show that you do own the product that you have attested to. And we're going to talk about that in more detail. I do want to show you something that may affect your certification number. If you go out to find your own certified EHR ID number, and when you go through the list, you find your product, and I pulled up a product here, and you can see it's Success EHS, and it's the version 6.1. It's a complete EHR, and this is the additional software that's required. So I put that into my cart, and when I click to get the certification number, this is the number that I get. Okay, so that's the number that I would use for my attestation. But look what happens to the number if I happen to have another product in my cart. So I have my Success EHS, but I was clicking through and I saw, oh, I want to look at Allscripts too. So I put that in my cart, and when I went to go get the ID number, it changes. So be very aware when you're going out to the chapel list that you only have the product that you're looking for in your cart, because it does change the ID number if you have multiple things in your cart. So let's talk about the audit process. If you're selected for an audit, you can expect to receive an initial letter sent electronically from CMS, and also you would get a letter via postal mail. Now this letter looks like this. This is an example of it, and it will come with CMS letterhead, and it will be addressed to the provider or the organization that is attesting. They will be using the address and contact information that you've submitted with your attestation. It will just describe that Figlio has been chosen to conduct the audits, and this letter is to inform you you've been selected for an audit. And they will attach a list of requested information. They also have given you a date when things would need to be submitted. They have an electronic communication system, or you can mail the information to the address that they give. Okay. So just to reiterate that you'll get an email, a postal contact, and they may call you as well. This is very rarely seen, but it may be used as well. What I want to caution you is to make sure that with your registrations that you're verifying you have the email address that you want to be contacted. Make sure that this email is a person that's going to check their email regularly, and also make sure that these emails, or you check your spam or your junk mailbox to ensure that this does not get dropped in one of those. Also verify your address and phone number in your registration as well. So some providers that have been sent the letter are seeing that the request for information can be as short as 2 weeks and could be as long as 4 weeks. 4 weeks is the longest that has been seen thus far, and the shortest at 2 weeks. As you know, 2 weeks is not a lot of time when you have other things to do as well, although this would definitely be a priority if you received an audit letter. Still collecting information that's needed, as you will see when we go through the required documentation. It's not something you want to wait to do until you receive a letter. Now, if you are finding that you just won't be able to meet their deadline, I would recommend that you ask for an extension very soon, because you wouldn't want to get a determination of not a meaningful user only by the mere fact that you weren't able to comply with the timeline. So this is the audit process. Like we said, you would get a letter. They would ask that you use that secure communication if possible. Any questions that they have, they will be looking at a desk audit. They will do that first. And they will be using the information that you send in response to the letter. In some cases, they may ask for an on-site review at the provider's location. And after that, they would make a determination. So they could make a determination from the desk review, or they may go to the on-site review and then go to determination. There's only 2 determinations to be made. 1, either you're a meaningful user, or 2, that you are not a meaningful user, and they will recoup any payments that have been made. The one thing that you want to try to do is to keep that auditor at their desk. Okay, so you want to provide as much information as you can to keep them at their desk audit, because if they are asking for an on-site review, they will probably be looking for more than just looking at attestation information. They're going to be looking at workflows, and they're going to be looking for a lot more than what you would expect. So just a recommendation, send as much as you can and keep them at their desks. So CMS put out the FAQ 7711, and you can look that up. I'm not going to bring it up, but this FAQ indicates in the verbiage that any single shortfall will result in recoupment of payment. So how do we protect against these shortfalls? Well, this is where you start to manage the risk of this whole process, and you want to make sure you have a solid plan on how to protect against a determination of not being a meaningful user. So the first thing is to ensure that you have supporting documentation. So you should know that it is written in the regulation that it's the provider's responsibility to maintain documentation that fully supports the meaningful use and clinical quality measure data being submitted during attestation. Now, if you're using a consultant or a third party to attest for you, this does not preclude the provider or the hospital from the responsibility of maintaining the documentation that supports the attestation. My recommendation, and several others have voiced this too in the audit community, that the best protection against a flag for any single measure is to have the following things. Now, you don't have to have all of these, but this would be my recommendation. A report that is generated from your certified electronic health record, or a log that shows the percentages or a numerator and denominator, and that report should show that it was generated for that particular provider or eligible hospital. Also, screenshots. It does give a static look for one shot in time, but it supports the report. The next level of support would be a policy with the effective date showing that this was the standard within your practice. And then also the workflow or procedure that shows how this data was collected within the EHR. These things may alleviate any questions that the auditor might have and prevent that site visit. So if you have a certified EHR, they are able to produce meaningful use reports, and I've seen quite a few. Many are very well done, and they're very pretty reports, and they have all the numbers and percentages. But for every meaningful use report, you need to be able to drill down to the patient level to show those actual patients that are included in the report. So if you have a report that comes from your EHR, that just has, 100%, it shows the numerator and denominator, you have to be able to drill down and show the actual patients that are in those numerators and denominators. This is the type of supporting documentation that you must keep. To be able to show your ownership of the certified software that you're attesting to, like we discussed, you will have to have the certification ID number, and you'll have to show proof of ownership of the exact version and all required modules for that attestation number. Now, it has been identified that Figlio will be looking at this particular issue only for 10% of all attesting hospitals and 20% of all attesting eligible providers. So they're going to be audited on this alone. So what data elements are they looking for in the reports? That report must show the date that report was generated. It must show the dates that are in the parameters for that's being reported, and it must identify on the report who the professional is that this data is generated for, or the hospital that it's generated for. So merely writing on a provider's name on a report will not satisfy. That needs to be generated out of the EHR, and it could be an identifier that was their doctor's NPI number or their name, but somewhere on the report it must show that this data is for that attesting professional or hospital. So any measure that has a numerator and denominator, you want to ensure consistency across the measures that have similar denominators. Okay, this is very important. It's one of the main things that they're able to flag on an automated basis. So any measure that has, and we're going to go through these in detail, but any measure that has in the denominator, it says number of unique patients, then they will be looking at the number of unique patients to be consistent across all of those measures. So let's define unique patient denominators, because I have had quite a few questions from people in regards to what is a unique patient. So if a patient is seen by an EP or admitted to a hospital more than once during the EHR reporting period, then for the purposes of measurement, that patient is only counted once in the denominator for the measure. So all those measures that are relying on the term unique patient relate to what is contained in the patient's medical record. Now for reporting, you'll need to be able to pull up all patients that were seen and be able to then deduplicate that list of patients so you can see just the unique patients, just that one time that they can be counted. So the measures, the meaningful use objectives that have a unique patient denominator are Core 1, which is physician order entry. Core 3 is the maintain up-to-date problem list. Core 5, the medication list. 6, the medication allergy list. 7 is demographics. Core 8, vital signs. Core 9, smoking. Menu 5, the patient electronic access. And Menu 6, patient-specific educational resources. So along with the report that you get from your EHR, the meaningful use report that has your percentages and your numerators and denominators, you'll need a drill down report that shows those specific patients as well. Patients that are measures and objectives that are asking to look if the patients are maintained in an electronic health record. These are two examples where you have to identify whether these numbers are strictly the patients that are maintained in an EHR, or if you're using patients that are outside the EHR and maintained within the EHR. If you are using data that is maintained outside the EHR, then you will need to be able to have a list of those patients as well. Any age-related objectives, like the Core 8 for vital signs, Core 9 smoking, 13 and older, Menu 4 patient reminders. These age-sensitive measures should be consistent with your patient mix of your practice. So if you are reporting on a Core 9 and you are strictly seeing newborns and you don't see anyone 13 years and older, and you attest to this beside an exclusion, this would be a red flag immediately. Yes and no measures. Yes and no measures are probably the thing that will require the most documentation and maybe the most difficult to attain. So getting to work on these as soon as possible is going to be very beneficial to ensure that your audit file is complete, just in case you do receive a letter of audit. So yes and no measures are Core 2, the drug-drug and drug allergy interaction checks. Core 11, clinical decision support. Core 14, exchange of key clinical information. 15, to protect health information. Menu 1, drug formulary. Menu 9, immunization, and 10, syndromic surveillance. I'm going to go through each one of these to identify what exactly you'll need to have for each one as supporting documentation. So for Core 2, this will require that you have some type of vendor report or audit log that shows that the functionality was turned on or active during the entire reporting period. Core 11 will require a screenshot of the rule used. So when you go into your EHR, you can be treating a patient and get a screenshot of that actual alert coming up where the physician has to make a decision. You can have a screenshot of that. I would also recommend to have these two things, the screenshot and then also the vendor report or audit log that shows it was active during the entire reporting period. Core 14, either letter, email, or other documentation that has the following elements, and this is exchanging key clinical information: the date of the test, the entity with whom the test was done, the structured data that was exchanged, and the name of the EHR that it was exchanged with, to show that this was a different EHR than the product that you have. Core 15 is to protect health information. A security risk assessment should be evidence that it was either completed or reviewed prior to the end of the reporting period for that provider or organization. A remediation plan was developed prior to the end of the reporting period, and that actions were taken prior to the end of the reporting period. For Menu 1, the drug formulary checks, a vendor report or audit log to show that that functionality was turned on and active during the entire reporting period. Menu 9, this is an email or letter from the South Dakota Department of Health, their immunization registry, that indicates the date of the test, that the test was received, that the test failed, and due to the fact that they are unable to receive the submission. Menu 10, excuse me, no test can be done because they don't have the abilities. So this will be an exclusion, and I will talk about the exclusions next. Just so you're aware, for 9 and 10, for that menu 9 and 10, CMS will be looking at your geographic region and see what others in your area are attesting to see if you're consistent with the others in your state. So let's talk about the exclusions. There's exclusions here, and I haven't put all of them up here, but these are the main ones that I think that most people have attested to, and what I have seen and what I've talked to people about. These were the main ones that they had attested to. So for CPOE, you'll need to have a report that shows the number of prescriptions that were written during the reporting period. So this is saying this exclusion is less than 100 were written, so you need to show a report that shows the number that were written during that reporting period. And it has to be under 100, just to reiterate that. Same thing for Core 4 for Ypresscribing. That same report could be used for Core 4 as well. Now for Core 9, the smoking status, a report showing the age of the patient seen during the reporting period would suffice. Core 12, that is the electronic copy of information. A report showing the number of patients that have requested information during the reporting period. Core 13, schedule of the provider for the reporting period that shows the number of visits that they've had. This is where they've had to provide a clinical summary. The only exclusion if you've had no visits. Menu 1, that is those drug formulary checks. Need to have a report that shows the number of prescriptions in the reporting period. Menu 2 is your lab tests as structured data. A report to show the lab test results that don't have a positive, negative, or numeric result. Now also menu 9 and 10 has exclusions. The report that shows the number of immunizations that were done during the reporting period. If there was no immunizations done, you can claim an exclusion. And if you're using an exclusion that there's no agency with capacity to receive, you will need the letter that we talked about in the previous slide. And you cannot take the exclusion that the registry is prohibited, because South Dakota does have a registry. Now for menu 10, a report showing that you have not collected any syndromic information during the reporting period is acceptable, or a letter or email from the South Dakota Department of Health indicating that they don't have the capacity to receive that information would suffice. Okay. Some more exclusions. Menu 4, a report showing that the EP has no patients 65 or older or 5 years old or younger with records maintained using the certified EHR technology, so that those are those patient reminders. And then menu 7, the report to show an EP who was not the recipient of any transitions of care or during that reporting period. And then for menu 8, if you have not referred someone or transferred someone, you need a report to show that as well. And we talked about 9 and 10. Just a miscellaneous one that doesn't fit in the other categories. For menu 3, where you have to generate a list of patients by condition, this documentation should have the date of the report, making sure that it is within the reporting period, and it shows the condition that is being collected, and also those patients detailed on that list. Now, the requirements for South Dakota program are a little bit different, and I wanted to bring those to your attention because several of the South Dakota providers are attesting to Medicaid. Everything that I just talked about is still applicable, and the supporting documentation is the same, but there are some extra things that you need during attestation that I wanted to make you aware of. So for they have some requirements for patient volume, for PA-led clinics, for your meaningful use reports, and I'll go into those into some detail. So for your patient volume report, you need to show a list of all the patients that were seen in the reporting period, and that should then identify those Medicaid patients, and you must identify them by either their name or their Medicaid number, the date of service, the provider who treated them, and that can be by name or NPI, and then the status of the claim. And they're really looking for paid claims. So if you can kind of filter out things that you know, haven't gone through or have gone through twice, just looking for mostly paid. I know some people aren't able to do that, and they will accept the reports that have everything on them. This is just what they're asking for if possible. So if one of the providers is attesting to say that they are a PA that is leading a clinic, Medicaid requires a letter that identifies the clinic and its address, and the PA then is listed that is leading that clinic. Your meaningful use reports, on top of having those reports submitted, you must also identify within your attestation certain information. For e-prescribing, you need to identify a pharmacy that you've been sending these prescriptions to. What we've used is just a name and address so they can do some verification if needed. When they ask in the attestation, they will ask you if 80% of your patients, of unique patients, they need that actual number that shows that 80%, and this is going to correlate to those measures that have that unique denominator. So they're looking for a verification as soon as you attest to say, okay, if 80% is 500, those are my unique patients, they should see 500 on every one of those measures that we talked about that has a unique denominator. So they've built in that verification right away. And they also ask the numerator and denominator to calculate that you have 50% of all of your patient encounters were in a certified EHR technology. So you'll need the total number of counters in the reporting period, and then the numerator is that number that are held within a certified EHR technology. So you'll need those numbers. For your clinical decision support attestation, you'll need the name of the rule that you used. So if you have you know, a rule for A1C, you'll get the description right out of your EHR that says this is the rule's title, and you'll have to enter that in your attestation. And then the menu objective of generating a list of patients by condition. In your attestation, in their system, you must list that condition. Now, we've gone through the supporting documentation. We've looked at who's going to be auditing. Now the question is, okay, now how do I keep all this information? They don't define the format that you must keep it in, but I would recommend that you keep it in a format that will be have longevity to it, in a format that you can protect and ensure that it is safe. Because your requirements are that you must keep the information and supporting documentation 6 years from your attestation date. So that means, let's say you attested for your first year of participation in 2012, you'll have to keep that until 2018. 2013 you attested, you'll keep that attestation information 2019. These programs, the Medicare program runs for 5 years, so you could potentially have information for quite a few years. The Medicaid program goes out to a participation year of 2021, so you could have information that you have to keep until 2027. So remember, it doesn't matter what format it is, but my suggestion is that you put it in a format that is protectable and it has longevity to it. All right, so just wrapping up, remember that they say that any single shortfall can warrant the recoupment of payment. So we want to protect about any shortfall that we can. So being overly vigilant about your documentation will not be a bad thing. Okay, if you are doing those recommended things of a report or a log that's from your EHR, the drill down to show what patients are actually behind that report. If you're using, supplying a policy, a screenshot, and then a process or a workflow, those things should alleviate and may alleviate any questions that an auditor may have. Remember that the providers or the organizations that are attesting are responsible to maintain that documentation. Recommendation is to do a pre-attestation document review, collecting that data before you attest so you don't have to be backpedaling to try and find that documentation after you attest. Be prepared, understand the requirements, and make sure that your vendor and your staff are able to generate those reports. You want to make sure that you keep Figlio and whoever South Dakota Medicaid hires as their auditing body, you want to keep them at their desk. That's your goal, to make sure you provide enough information to keep them there. Verify your information on the CMS registration attestation website to ensure that your notification contacts are accurate. And to maintain this information for 6 years post-attestation date. And remember, if you are attesting for multiple years, you'll have to have each one from the attestation date for each one of those submissions. All right, I'm going to open it up for any questions, and I am going to go ahead and see if you have any in the questions box. I don't see any there, none in the chat. So if you wanted to raise your hand, you can go ahead and do that, and I can unmute you. Or you can go ahead and enter them in the questions box. All right, well, I'm not seeing any at this time, so we'll go ahead and close for today. I thank you for your attention, and if you have any questions that you'd like to talk about offline, my contact information is here. You can also visit our website at healthpoint.dsu.edu or just give us a call at 256-5555. Have a great day.